Good morning, colleagues. Good morning, everyone. A very warm welcome to this side meeting on peace through health and gender at the 2024 Prince Mahidol Award Conference here in Bangkok. All of you are very warmly welcome to this side event, which is an event co-organized by several wonderful partners, academic partners, practicing partners, international organizations, including the Lancet Commission on Peaceful Societies Through Health, Equity and Gender Equality, WHO Regional Office for the Eastern Mediterranean, Prince of Songlaka University, Thailand, and Deep South Relief and Reconciliation Foundation and HITAP. So this event is going to be a full-day event divided into two sessions, a morning session dedicated to the Eastern Mediterranean region of WHO, which is Middle East, North Africa, and Southwest Asia, and Europe. And the afternoon session is going to focus on Southeast Asia. As you could understand, peace, health, and gender are complex subjects, and we have a diversity of topics and contexts coming around these subjects, and we wanted to have an organized agenda around this day, and that is why we have divided this into two sessions. But before saying anything further on this session, let me invite two co-organizers, Professor Veersakardi Chongsuk Vivatong from Prince of Songlaka University, Thailand, to come on stage. And let me also invite Professor Peter Freiberg, the co-chair of the Lancet Commission on Peaceful Society Through Health, Equity and Gender Equality, to come on stage. So, as I said, Professor Veer has been a wonderful host, a wonderful collaborator, and a wonderful mentor also to so many of us. And he's also our host here in Bangkok. Before starting the session, I would like him to say something on behalf of the university and also on behalf of our organizers here in Thailand. Professor Veer?
First of all, welcome everybody to Thailand for this important PMAC conference 2024. On behalf of the Thai host, which consists of HITAP, Prince of Songkhla University, Deep South Relief and Reconciliation Foundations. We are very pleased that you can come online and also on site to have this important meeting. Prince of Songkhla University team has, I think, 8 of them is supporting this one, running webinar and announcement. And this session is also live on Facebook of Prince of Songkhla University. So it will be recorded, and people who do not attend here can attend at any time, can look at any time. So we hope you have a fruitful, wonderful, and a lot of discussion about these important issues, geopolitical conflicts and health and peace and women's role in development. Thank you very much.
Thank you very much, Professor Veer. Professor Peter Freiberg, would you like to say something as a welcoming note to all of the colleagues here online?
Thank you so much, Vasik. It's a real pleasure and honor to be here, and I am very grateful for you and planning and doing all these things together with Dr. V as well. I'm very happy for that, and that we can be organized here at the PMAC 2024. So with that, I would like very much to welcome you all, and as Vasik was saying, to discussing these quite important issues and what kind of these problems that we actually are facing in the world today. So thank you so much, and we're very welcome.
Thank you very much, Professor Freiberg. A bit of introduction of my own self. Wasik Khan, I work with WHO's regional office for the Eastern Mediterranean. WHO, as some of you may know, have 6 regional offices, and one of the regional offices is based in Egypt, and that office looks after 22 countries of Middle East, North Africa, and Southwest Asia. And as you could imagine, several of these countries are facing conflict and facing the complicated situation as a result of conflict in terms of its impact on health and development. And My job is to work on the Health Emergencies Preparedness and Response Program, which is a critical component of our work, that means WHO's work in that region. And we are very pleased to have this collaboration with Professor Freiberg, Professor Veer, and other colleagues. Colleagues, this session is going to focus on how peace can be revitalized in terms of its creation, in terms of its sustaining it, in terms of its promotion through two powerful drivers. One is health and the other one is gender. But our focus primarily is going to be on health, and we are going to talk about some evidence around it. We are going to talk about certain key studies that are coming out of these conflict-affected countries, how the work is being done, some reports of these countries in terms of the latest conflicts that we have around the world, particularly from the region that I represent. And then we are expecting that we will have an insightful conversation around those conflicts as well. And then we can see how these two powerful drivers, health and gender, can be taken forward in terms of promotion of peace, sustaining peace, and development of peaceful societies in our countries. But before we do that, a short video that we developed at the WHO regional office to emphasize upon our work and also to introduce people to the concept of health as a bridge for peace. So if my colleagues can run that video, please. It can be projected on screen. And the volume can go a little bit higher, up.
As a result of conflict, in 2017 alone, 68.5 million people were forced to leave their homes, including 25.4 million refugees. Violence is a major source of disease and ill health. Absence of peace has devastating effects on human health, directly with injuries from fighting and indirectly by the breakdown of health services. When conflict rages on, healthcare is increasingly under attack.
Can increase the volume?
In 2018, across the world, about 1,039 attacks injured or killed more than 635 healthcare workers, damaging about 360 health facilities. The majority of such attacks occurred in the WHO Eastern Mediterranean region. The region has the highest volume of conflict, refugees, and disruptions to the health systems in the world. Conflict became the new normal. However, health is neutral and apolitical. Health can be a meeting point to bring conflicting parties to discuss mutually beneficial matters. Because of their professional and ethical position within the community, health workers are ideally placed to promote peace through health. In 1948, the WHO Constitution stated that the health of all people is fundamental to the attainment of peace and security. In the mid-1980s, UNICEF, the Roman Catholic Church, and other organizations negotiated Days of Tranquility in El Salvador. Fighting was suspended for the immunization of children for 3 days each year from 1985 until the peace accords in 1992. Between 1996 and 1997, WHO facilitated negotiations between the Croatian Ministry of Health and the Eastern Slavonia Serb leaders on public health issues, and facilitated cross-community contacts through joint health workshops and seminars. It's time we give health a chance to promote peace in the Eastern Mediterranean region. As partners in health, let's join hands and work together towards peace.
Thank you very much. Thank you. Apologies for this technological issues, which is technology is always a facilitator, and sometimes it is not as much a facilitator as people think it is. So apologies for that. But with this, we can move on to the other part of the session. Now, when we say health as a bridge for peace, a critical element that several skeptics raise is the evidence. Where is the evidence that health can be a powerful driver towards peaceful societies, towards the sustained promotion of peace and sustaining peace? A critical piece of work that has recently been done has been by the Lancet Commission on Peaceful Societies, and we are fortunate to have Professor Peter Freiberg here, who was the co-chair of the commission, and, a tedious task that he led, but a wonderful work that he has led, and a wonderful outcome that has been created through that piece of work, which is globally very critical and important for us as practitioners on ground, and for academia, and for those who are proponents and advocates of this field as well. So Professor Freiberg is going to share the outcome of the Lancet Commission, and what are the key messages that are coming out of that commission, and what are the recommendations of that commission. So Professor Freiberg, if you can take us through the commission findings.
Thank you. I think I like better standing to present than to sit down. So thank you very much, Vasik, for this, and the opportunity also to present some of the results that came out from this commission. Now let's see here. Yep. So in 2019, we established this Lancet Commission with the aim really to see what are the evidence for health investments and health equity, and also gender equality, to actually provide peaceful societies. And let's see. On the back. It doesn't make any difference. It's okay, yeah. And in the meantime of what's happening since 2019, there is quite a few things happening. And we already before 2019, we had quite a complex world with lots of conflicts going on in different parts of the world. And during the commission work, we had a new conflict between Russia and Ukraine. And even so, I mean, about some time back, we also had a further crisis in the Middle East with the Israel and Hamas war. So in that context of conflicts and wars, we also have other things with the climate and biodiversity challenges to handle at the same time. And the need for humanitarian is absolutely staggering. So we are having a time with a polycrisis, and to navigate in this kind of world now is not an easy task. What we have tried to do is to focus then on, with the Commission, with the conflicts, with based on organized violence within countries. And as you are well aware, there are quite a few things going on in this world with conflicts all over the globe. And it has been escalating during the last 10 years. And this is a data from the Uppsala Conflict Data Program. The Commission built on 3 SDGs. That was the original thoughts. We have number 3, 5, and 16. And 3, as you all are very well aware of, good health and well-being, and then the gender equality and the parts of the SDG 16 with peace conflict. But within the SDG 16, you have many other things as well which are important for stability of societies, like institutions, the strength of institutions, and the corruption, and all those kind of ingredients. So with this, the purpose was to try to get together people from different perspectives, different disciplines, to work together on this. Because we have gender researchers, health researchers, peace and conflict researchers, working together, which was not an easy task, I can tell you, because we have all very different cultures. But this is the only way that we believe to move forward. So we would like then to try to establish then what kind of empirical evidence are there in the different databases from the different disciplines and perspectives, and see how that could be linked together. And then to try to contribute to national and global policy development, of course, in this, as was also alluded to by Vasik. So the hypothesis and the basis for the start of the Commission was really to form a couple of hypotheses, which is quite simple in a way, but difficult to establish with evidence. So that's our task. First, you have also the harmful cycles where health inequity relates to gender inequality in both ways, and that of course related to violence. It's a vicious circle that goes around. So the task is really to try to break this vicious circle, to move with certain mechanisms into more of gender equality and health equity will then resonate into more stability and peaceful societies. And that goes also independent of each other. So these were the hypotheses, and having also then gender equality and health equity together would further enhance the stability and lead and the pathway to peace. So what we have done is to try to see about case studies from the various countries and what the processes are there, and also to have a comprehensive literature reviews. So I try to be brief about this, and there is a lot to read about this in the publication, and I want you to take, every one of you in here, to take a copy of that to further read, should you have the time and interest. So, I mean, starting in this corner here with a harmful cycle, as I said, are interrelated with each other here. So to try to break this with the various mechanisms and principles like advocacy and institutionalization and bringing dignity and these various kind of mechanisms, try to break that to move into an improved health equity and improved gender equality. Separately, but also combined, of course, preferably. And by various capabilities like individual agency, changing structures within the society and the community, hopefully then shifting power within these systems, transforming then a society by means of economic effects, social effects, and political effects, leading to increased human capital and inclusive economic growth, of course, and social capital, the social contract with the citizens and the council and the governments, and also something extremely important to have some kind of quality of both governance, of course, but that also that you can trust, because that leads to increasing trust and beliefs in the system. And if we are lucky then, that leads then to actually coming from a vicious circle to a more beneficial circle, where health equity, improved health equity and gender equality actually leads to peace, which then in turn reinforce the economic, social and political effects. So this is really the scheme and the way of what we have worked, and provided then evidence and for the different steps. So some of these main messages that came out of this commission then, and we focus here on 4 messages. With health equity and gender equality have a unique and powerful ability to contribute to more peaceful societies, both for gender itself and health by itself, and also further strengthened by the combination of the two. So the health equity and gender equality principles and processes that must be also context-wise from the inside-out processes, led by communities, tailored to exactly the context where we are discussing, and not so much from above. I mean, it's a combination, of course, but I mean, the important thing is to start inside out. So policymakers must then embrace, advocate for, and advance gender equality. That is very much lacking in this context. Of course, health is very prominent. We all know that, but we need to have some other components as well, very important, and particularly gender equality. So health equity and gender equality must form an integral part of national and global processes to promote peace and well-being. So then based on, I can jump this because it's quite similar. So based on this, the evidence that we have found in the different steps, I think there will be also something of a learning agenda here. For example, that there are still quite a lot of knowledge gaps that we need to be researched, need to be explored, need to be followed up. And we need more of a conflict analysis also, because they are very different. Many similarities, of course, but also a more scientific approach to this. The most compelling things that we experienced in this commission was the interdisciplinary work, which, as I said in the beginning, is not an easy task because we have all different countries. But we need to understand each other. We need to try to see how do we do science together in a good way. And not the least, also work with organizations and people and researchers also on the ground, what is actually happening in the real world and not just in the universities. That means also the implementation research would be crucial. And there is also some country cases that you can read about in the Commission. The diversity of perspectives need to be considered. And we need to have also people involved from the affected areas as well, and countries. We need to be critical, of course, to these empirical methods. What we have done in our Commission, trying to combine databases, and being quite effective also science and the validity of the data, because there is a lot of also lacking data, of course, but also some grey literature that have been considered. So this is just a very brief reflection of what the purpose of this commission, and you can read much more. There is also, besides this publication, there is also an appendix which is quite substantial, but have a lot of the basic and data and exactly how we did it and all the indicators, because you have to have a lot of indicators, and those are the problematic sometimes to research in different contexts. But I mean, for example, one important indicator is, of course, child mortality in various contexts of war conflict. So that's one example of an indicator. So we got support also from the Swedish Minister of Foreign Affairs. We had from IDRC from Canada and also from Finland. And I must say it was fantastic also to work with the Finnish government and the President Tarja Halonen we had as a chair. And it was fantastic also to, from her non-academic perspective, also to bring important views into the Commission. I would also like to say that when we published this paper, there was also a comment written by Vasik Khan on the EMRO perspective in relation to the Commissioner, which also bring out more the health perspective. I think you will come back to that. But that was published at the same time as a very good example of how the Commission also could be used. So thank you so much for that.
Professor Freiberg, thank you very much. A wonderful piece of evidence practice that has been missing previously. In fact, the previous studies were, when we started working on it in 2018-19, we realized that the previous studies were either done in the 80s or 90s. And the missing part was the 2000 decade that was not there. So thank you so much for bridging this an important gap that was already there and identifying several other pathways that we need to work upon, all of us as academia and practitioners as well. It's an interesting opportunity to ask questions from Professor Freiberg regarding the Lancet Commission. So anyone would like to ask any relevant question or comment? Professor Veer first.
Because peace and violence is cyclical, you identify the transit from bad cycle into good cycle. Have you identified the opposite direction?
Well, as the arrows indicated in the circles, they go also on the other way as well. So, I mean, you can lose control as well. Yeah, absolutely.
What is the mechanism that moves from good path to bad path? For example, there might be a threat, international conflicts, right? Which, because of political agendas, etc. But how can this be prevented and solved?
Yeah, and I would just say also that this was more not international conflicts in a way, it was more organized violence also mainly within countries. And I mean, loss of power or a coup or something like that, that might happen that takes away the stability. That can go just overnight. So that would be one mechanism, for example. So that means also that I mean, the institutions and the strength of trust among people is so important. And if you have a good stability, then it's much harder to actually crash that in a way. But when it's weak, it's easy. The government, as you know, can fall just on one day.
Okay, so this is mostly within country, right?
Yeah.
Conflict.
Yeah.
Thank you very much.
Thank you, Professor V. Professor Raza.
Thank you so much. Very interesting. I'm curious to know about faith. Sure. My name is Reza Majdazadeh. I'm right now professor of global health at the University of Essex, UK. Very interesting paper. I really appreciate that. My question is regarding the pathway itself. What you have shown was that, let's say, a part of the pathway is about three main, let's say, subjects. One is the human capital, one is social capital, and the other one is the quality of governance. I'm wondering if we can have some sort of measurements to, let's say, to empirically assess the, let's say, the correctness of this pathway or not. And do you have any thought on it?
I mean, there is a lot of various kind of data that you can try to collect together. But an example of the governance is that there is an institute at university in Sweden which has a special department which is called Quality of Governments. And they have actually an institute dealing with gender, peace, conflict, what health means, for the stability of governments, but institutions, corruption and so on, and actually have indexes and scores and measure it in a more standardized way. So that's one example, and that is quite compelling, those kind of evidence, and that's hard evidence, and that's global index as well, and scoring system. So that's one example that you can follow that.
And how about the other two components?
More complicated, I would say.
And is there any, let's say, complex measurement to use all three all together?
That we haven't really looked upon that.
Thank you so much. Thank you.
Espen Bjartnes, University of Oslo. I like this idea with to break the cycle. And you have in your model several of the SDGs. But I think something is missing in front of the model. That's about the humanity and moral. Because I think we need high moral to reach justice. And looking at Gaza, for example, we will talk more about it in next part. But moral, I think it comes from the experience during life, what we learn during life, and what kind of knowledge, indoctrination, everything contributes to moral. So a determinant of moral is what is it to be a human being? And have we really forgotten what humanity is? Is it so? I mean, that's to help people, to care for people whenever needed. But security, transparency, accountability, and forgiveness is a part of the model. But there cannot be peace without justice and moral. Do we need to teach people humanity from kindergarten, school, at the university system? Have we forgotten what it is? And it's missing in the model. That's one point.
Very good point, Espen.
Because we are run out of time, right? So what do you think we should move or have one more question?
One more intervention.
Okay.
And Peter, if you can quickly answer.
Yes. Espen, I would just say that, I mean, I think that your question was rhetoric. And the ultimate answer is, of course, yes. Hard to measure, though, but I mean, I'm sure you know that the books and pieces written by Professor Peter Wallensten at Uppsala University. He had the first Swedish professorship in peace and research, and that was called the Dag Hammarskjöld Professorship. And he has written pieces about quality of peace, and he speaks a lot about the dignity and moral and those kind of things. And so you're absolutely right. That is something that is inherent in all these kind of discussions and the modeling as well. But it's just to try to get some figures and data on it. It's a bit more complex.
Thank you very much.
Thank you for your point.
Thank you, Peter. Last intervention.
Great. Peter, thanks a lot. Going back to your model, I'm just wondering about external. Dennis Carroll, Chief Science Officer for URC. Peter, going back to your cycles, I'm thinking about external forces, and when you talk about violence, the role of the arms industry and economic drivers that really distort. You know, all of the external forces are not equal, so when you're trying to drive the cycle to the right, there are external forces which are driving it even more profoundly to the left. And wondering if you could say something about the role of the arms industry in this.
Yes, we have another session in PMAC main conference about arms race and humanity and geopolitics. And I mean, there's a lot of friction now going on geopolitically as well, and the arms industry is one of them, of course. And I cannot say we haven't researched that, but I appreciate very much other factors. And for the plenary too, in this conference is commercial determinants of health, and the arms industry is within that as well, affecting on different levels. I mean, not just people's health in itself, but also governments and the lobbyists and all these kind of things. So absolutely, this is maybe more what we have presented with these models is an easy way out in a way, because there are so many factors that are contributing and disturbing the circle as well. And one of them greatly is arms industry, of course, like other industries in other fields. So absolutely, Dennis, you are so right. And I can't comment exactly what but we all know that the influence is pretty much. Yeah.
Thank you very much, Professor Peter. Thank you. And we will be taking the discussion forward as other speakers speak. So the next speaker who's online, Dr. Akihiro Sita, is the Director of Health, and he represents United Nations Relief and Works Agency for Palestinian Refugees in the Near East, commonly known as UNRWA. Now, let me admit, several people, particularly among us, were not very well aware of the work of UNRWA, but it has been highlighted how crucial the work of this important UN agency is in the context of Israel-Palestine conflict that has been ongoing for decades. 7th of October, a militant group attacks Israel, and as a result, Israel unleashes an unprecedented retaliatory response on Palestinian territories, and what we have seen is unprecedented tragedy that is happening in that part of the world. But UNRWA is at the forefront in terms of its response, and Dr. Akira Sita, as the Director of Health, is leading that response in terms of providing healthcare services and meeting the unprecedented needs of health and social well-being that is needed on ground in that context. The conflict is ongoing. What is happening in that conflict? What is being done in terms of the response that is being mounted by UNRWA and other UN organizations? We have invited Dr. Akira Sita to come and present this. He was expected to be here, but unfortunately, because of the unprecedented demands of work that he has back in Amman and in Gaza, he was unable to travel. But we are very grateful early morning that he is joining from Amman. Dr. Sita, if you can, I hope you can hear us and you can see us, and if you can project your slides and present your slides as well. Dr. Sita?
Yeah. Hello?
Yes, Dr. Sita, go ahead, please.
Okay. And then let me try. Do you see the slide?
Apologies for this technological hiccup.
Hi, do you hear me?
Yes, we can hear you. Can you hear us?
Now I hear you, yeah.
Yes, go ahead, please.
Okay, thank you. So good morning. It's very good morning here. It's 5:30, and I'm really sorry I could not make it, and because of this reason, Wasi could kindly elaborate it. So my name is Satan, head of health of UNRWA, which is the UN agency for Palestine refugees, taking care of the Palestine refugees starting from 1948, and at present we have 6 million Palestine refugees in Gaza, West Bank, Jordan, Lebanon, Syria. And today's talk is of course in Gaza, which is probably the most far from anything of peace we can talk about. And I share the work in the UNRWA into health, but firstly, that today, almost a week ago, that this war reached 100 days, and this is a summary of the 100 days in the health cluster and WHO on the left. So the fatality is almost 24,000. It's quite big ones, and then in health system-wise, you can see on the left bottom that how many hospitals damaged, how many hospitals not functioning, and how many primary healthcare centers are not functioning. So health system is massively deteriorated, and the attack to healthcare is significant. More than 600 people killed, and more than 700 people injured, and so it is extraordinarily deteriorating health crisis or humanitarian crisis we have ever seen. All my friends are working with the humanitarian assistance confirmed with me that they have never seen this kind of crisis. And the degree of the deterioration, the size of the casualties, and the massive size of the internal displaced people, or IDP. On the right is the latest threat from the UNRWA, from us, that 1.7 million, which is almost 80% of the people living in Gaza, are displaced. And some of them are multiple times, and many of them are going to the southern part of Gaza, which is called Rafah, accommodates 1.4 million people. Originally, before the war, that they have only 300,000 people. And so in Rafah, the streets are full, shelters are full, and then everything is full. And then for UNRWA, that we already lost 151 staff from the start of the extraordinary sad situation. And then incidents in the health facilities and the incidents of shelters are damaged. But these are only the numbers. And let me share that recently we had a conversation with our staff in Gaza. We asked them that how can we help you? Because we've been having this dialogue since the beginning. And this is the one we got yesterday. And Dr. K said that on the left top, to deal with Gaza people as human and stop this war. It's a very common response from them, stop the war. And on the left bottom, that nothing can treat us our souls. We are not suffering, we are dying in Gaza, and no one feels us. This is sort of feeling of the abandonment or left alone is extraordinarily strong among our staff in Gaza. And they are extremely, extremely angry with the international, against the international community, and also this part of the world. And Miss T and Miss S, on the right top, that to secure all the necessities, to secure all necessities, all needs of life, requirement to live like any other people in the world. And one of them said on the middle that provide some clothes for the children in this very cold weather. So it is an absolutely horrible situation, and which you may see in the news, but I can guarantee you what you have seen in the news is only fraction of what is going on there. This is extraordinary situation. So I share that the health service of UNRWA in the next several slides, and to show that how we are trying to respond to this massively deteriorating and unfortunately not ending crisis. Before the war, UNRWA has 22 health centers on the map in the order daughter health center throughout Gaza, taking care of the 1.3 million refugees or the almost 4 to 5 million medical consultation every year. So it's quite a large operation with 1,000 staff. And as of last week, that the situation is basically the same, or if not worse. Only the 6 out of 22 health centers were functional. They did start with vaccinations with the help of UNICEF and WHO, but the 74 shelters out of 100 plus has a medical points, 86 medical points, because some of the shelters has multiple medical points. Medical point is the medical treatment facility with doctors and nurses with 1.6 million persons. But in the previous one, we issued this health slide deck every week. In the previous week, we have 80 shelters with 90 medical points. So it is declining because of the ongoing hostilities. And then the population per shelter is 21,000. And it was 15,000 last week, which means that people are moving and they're making IDPs. Before the war, that we prepare for the war, this kind of emergency situation in Gaza, because unfortunately the war is not new to Gaza. But then we prepared well, but at that time that the size of the shelters we may accommodate is 2,000 people, because that's the largest number of the IDPs in the shelter in the previous all the wars. Now it's 10 times higher. So you can see that how we can make any response or how mission impossible situation is. And the 22 shelters do not have the medical points due to security situations. It was 16 last week, and so the week before, and so that the 5 increase or 6 increase. And the contracted hospital all partially functioning. So this is for me, this is a great number that out of 1,000 health staff, 690 are still working, 400 plus in the centers, and another 200 plus, 250 plus in the shelters. So these are the people who are continue to work to respond to the suffering or anything they could do in these very difficult conditions. But medical consultation on the rise. Before the war, with the 22 health centers, we had 15,000 consultation every day. Now it's 23,000, as you can see on the table below. It's 12,000 health centers, 10,000 shelters, 23,000 as a whole. And previously, that UNRWA is mandated to take care of the refugees only, which is 70% of population in Gaza. Now that we are treating every single person in the Gaza, and in the health centers, it was 12% of the people coming to a health centers are refugees. Because some of them still uses the Ministry of Health and the other clinics or other hospitals remaining functional. But this percentage of the non-refugees are on the rise because of that massively deteriorating health services situation in Gaza. And so because of this, the number of people working is less than before the war, but number of patients are more than the war. So before the war, that each doctor sees 55 patients a day, and now that they have the 100 plus patients a day with a range of that in the shelter reach the 200 people a day, and the health center 170 a day. This is not the idea at all, but this is a reality, and they are working with such a situation. And then we introduce afternoon shift, so 2 shifts a day to cope with this increasing needs. And the shelter situation is horrible. It's a disaster. Because of that, firstly, that the water situation is extremely complicated, if not difficult. They have only the less than 9 liters person per day, which includes 1.6 liter potable water or drinking water on average, and 7.2 liter for the domestic use. According to SUFARE, that the minimum needs is 7.5, so it's bare minimum, but also 2.5 liter drinking water is needed. And so that they are really surviving without sufficient amount of water and the food. And so if you see the toilets, one toilet is used by 560 on average. Some places more than 10,000 because scarcity of a toilet. And the shower is almost 3,000 per one shower per 3,000. And of course, the ideal is that 20 person per toilet, 20 person per shower, but it's very far away. But I must state here that the shelter is better because many people are living on the street and they're using that any place to use as a toilet, and there's no shower outside the shelter. And so its situation is extraordinarily difficult. And now that it's a winter season in Gaza, and so it's a rainy season, so life is absolutely horrible. Because of this, that we are monitoring every day that epidemic-prone diseases by having from the medical point from all the shelters and the health centers. And the massive crisis now is hepatitis. It's probably hepatitis A. Together with the help of WHO, we did a laboratory test and we found that they are hepatitis A, and then it's not hepatitis E. That's a good news, but this size of increase, in particular the middle area, is a major concern. Acute respiratory infection continues to remain high, and the diarrhea, watery diarrhea, bloody diarrhea, is always it's always on the high end. If we compare this diarrhea before the war average, it is almost 30, 40 times higher. It looks like a flat, but it is extraordinarily high. There's no cholera yet because it's not endemic, but the situation is extraordinarily high. So that's a health without peace in Gaza. It's a massive, it's absolutely no doubt a humanitarian crisis in health, as I explained. Now, damage to health services. Now, in UNRWA, that only 6 out of 22 health centers are functioning, but we still have 35 pregnant women in taking care of in health centers every year, or probably around 50,000 all in Gaza every year. And we have 45,000 people with diabetes, which we are treating every year. So continuations, the health services are at risk. And the health needs increase, injury cases, almost 20 to 30% of people who are taking care of the health centers, shelters are wound care. Because hospital cannot cope with the increasing demand, so they will discharge the patient prematurely. They come to our health center, shelters to wound change. Infectious diseases, mental health is a massive crisis. And then recently announced the World IPC, the malnutrition. We have started checking and screening the babies and infants together with vaccination malnutrition status. But if you go to Gaza, they simply say, we are hungry. And attacking and serving health workers. As I shared in the voice from the health staff, we are not suffering, we are dying. And many of them tell us frankly that we are waiting our turn. The humanitarian assistance crisis in health, because increasing, we do, I have to acknowledge that we do work very closely together with all the partners, the WHO, UNICEF, WFP, and the OCHA, and everybody. There's increasing support. Say, for example, even in UNRWA, that we already bought 6 months quantity of all the medicines. However, because of a geopolitical affection, the impact that everything is very slow. All the medicine we bought haven't reached. Some of the medicine we bought haven't reached to Gaza yet. And because of different reasons, security is also a major concern. This affected our operation in the northern part of Gaza. We are not able to provide a service officially. And also public perceptions going around in different parts of the world. So that there's no humanity in Gaza. And the people in Gaza say, no one feels us, everybody left us. So should we give up under such a situation? And of course, absolutely not. For me, there are two things that are important. One is that we have to make sure that health service continue to run against all odds. Because that's the lifeline for the people in Gaza and also the people who are injured in Gaza. So it's important to continue to support the health infrastructure and supply chain. And the most importantly, health staff. They all complain that they are also part of the IDPs. Some of the staff are staying in the shelters or even on the car on the street and come to work. So we need to help them. We need to provide them a basic life needs that we are trying to do this. And also we need to continue to have advocacy financial assistance, but it needs massively more amount of money and support. But at the same time, it is critical for the people in the global health or international health to put the health as a core of humanitarian assistance. Because the reason is obvious, because health is massively affected, but also when the hope that when the war ends, that the health should be put as a core in the humanitarian assistance. Needs a global advocacy and also the collaboration within the Palestine. That's important to make sure that health is put in the center of the humanitarian assistance or reconstructions, but also that it's important for the understand governing framework, how the current crisis continues and how the reconstruction will start. It's very difficult questions. Nobody knows yet what kind of a governance framework is there, but it's important to have a dedicated funding, specific funding for Gaza, and then that's a sustainable financial mechanism on the health. But it's important for us. I feel privileged to work in Gaza now because this is the massively crisis. I think all of us felt we are privileged to work in the time of COVID era pandemic. So Gaza is one. So that my sense is that Gaza's recovery starts with health, because health should be the center. And that is the answer to Wasi's question, that will lead to the health for peace and the peace for Gaza. That's all. Thank you very much.
Dr. Sita, thank you very much for this. Dr. Sita, can you hear us?
Yes, yes.
Thank you very much. A wonderful reflection, heartbreaking, unprecedented, but at the same time, please accept our huge admiration and appreciation for the work that you are doing, all of our staff are doing, and others are doing in this unprecedented conflict that we have not seen in our lives before. Questions and reflections for Dr. Sita's presentation from the audience?
Maybe we need some women to speak because for gender equities.
Espen, if you can introduce yourself to Dr. Sita also.
Yeah, thank you, Dr. Sita. My
Hi,
name
how are
is
you?
Espen Bjertnæs, and we know each other. I have been working with Palestinian universities for a long time, since 1994. The situation in Gaza is terribly, as you have described. I talked with Doctors Without Borders recently, and they say that the situation for health personnel is worse and worse. For the last 20 years, more and more health professionals, health workers are killed, ambulances attacked, health facilities destroyed. But how can we stop this? This is about humanity again and moral. How can we stop this development? It's terrible. You don't feel safe when you are caring for wounded people.
Dr. Sita, any comments?
If I know how to stop the war, I could be the, I don't know. I think it's entirely politics, so that if you go to ask the core question how to stop the war, it's entirely politics. And so that is what we are expecting international community to give a pressure to the parties concerned, but also the parties influencing. And I really appreciate a global voice to support the Palestinian civilians. But at the same time, we should continue to raise our voice as a health workers, because as I said, that the attack to the hospital not acceptable, killing the health staff not acceptable, and the stopping the medicine influx to Gaza is not acceptable. I think we really need to raise the voice of the humanity to show the solidarity to the people, civilians in Gaza. And that's what we really need to do. And showing the numbers, showing the voices, and then giving the pressure to the politicians who can make the final action, if not decision, towards the peace. Over.
Thank you very much, Dr. Sita. We have one more question from Professor Freiberg.
I would say that if you take a long-term perspective on trying to stop, not just exactly that war, but in the future, bring more gender balance in there.
Thanks very much. Professor Raza?
Just let me seize this opportunity and give my esteem to Dr. Sita. We know each other from 1997 when I was working in tuberculosis program and under his actually direction. The presentation is heartfelt, and I know how you are actually committed and hard worker. My question is about the link of the, let's say, the video which we have seen at the beginning and the presentation of Dr. Sita. What is the, let's say, what has been done for the link of the health for peace, and whether you had done any advocacy on, let's say, to connect the health status of the people over there with the peace or not, and what was the experience in this regard? Maybe it is more related to the Dr. Wasikhan rather than the Dr. Sita. Thank you.
Thank you very much. Sita, would you like to say something before I can comment on Raza's question?
Oh, you go first.
Thanks very much. So, Raza, great question. The challenge of this conflict is, and let me answer this in a different way. Peter also mentioned in his presentation on Lancet Commission, conflict analysis is critical if we want to take the science and the work on health as a bridge for peace forward. Because each conflict is different in terms of its drivers, in terms of its impact, and in terms of its dimensions, different dimensions that are involved into it. Palestine conflict, Israel-Palestine conflict is uniquely different. And more than 70 years old conflict. We have been working on this as health as a bridge for peace in Palestine, I think more than others in terms of historical context. But this war and this conflict has changed all that work. Let me say all that work has been dumped and we are into an uncharted territory. We don't know when the conflict is going to end. We don't know rather I could say, we know where it is heading in terms of destruction, but we don't know what prospects are there for peace. No one can answer. Even probably people in Israel cannot answer. People at international community cannot answer. We are in uncharted territory in this conflict. But I repeat the question of Sita's slide. Should we give up as health, humanitarian, academicians, scientists, as people who are proponents of this field? No, we cannot. Because if we give up, then we should give up our own core values and our core work. And that's why we should continue to work on it. We should continue to advance the work that we are doing. However, the nature of that work, in the moment of that, in that moment will be different. At the moment, we may not be able to talk about peace, but at the moment, the need is to provide the humanitarian support and respond to the unprecedented needs of those people who need shelter, who need health support, who need education support, who need toilet support, water support, etc., etc. So, Dr. Sita, any final words before we move on to another flashpoint?
There's one lady waiting for comment.
Okay. So, sorry, Sita, we have one question, and then we go to you for final word.
Okay, I think you sort of covered what I was going to comment on. I have a comment rather than a question. I think as a public health practitioner...
Can you identify yourself?
Sorry. My name is Natasha Howard. I'm an associate professor at NUS School of Public Health. And I think as a public health person and as a conflict scholar, I think it's somewhat incorrect to call it a war. I think it's more of a one-sided slaughter. In the midst of a much, much broader, longer-term conflict. So I think as public health people, we really have to look at what are the outcomes that we can do something about, while at the same time trying to apply some sort of better lens and longer-term lens in terms of all the other aspects of it. But in terms of day-to-day how to improve the situation for people, it's not just happening in isolation, right? So there's not much that we can do on the day-to-day if we don't look at where it is situated in terms of geopolitics, etc. So it's quite hard to separate that out, even though as clinicians, as public health people, we try to do that and just focus on the microcosm. I think this is an example. It is quite unprecedented of a situation where it's quite hard to do that. Thank you.
Thank you very much. Dr. Sita, any final words?
Yeah, thank you very much. I think this Gaza is probably the biggest challenge that the entire global health is faced. Yeah, and we should never accept the status quo as it is. Yeah, that's what we can do is quite a difficult question to answer, particularly now. But there are so many things to do. What we will do is it could be a drop in the ocean, but each drop of the ocean that could make an entire difference at the end. So it's important for us to keep on trying to do. But at the same time, in the mid to long term, particularly in the reconstruction happens, that it's important the global health community to make sure that health is the center of the reconstruction. Agenda that just for, yes, agenda is very important, and we have a great female leader coming to the session, in the main session, thanks to Wasik. So you can mention this at the end. Yeah. Thank you very much. And I apologize again that I'm not in the room today.
Dr. Sita, thank you very much. Thank you very much. So Gaza will be featured in the main conference sessions as well. Dr. Ghada, who is leading the health response in Gaza under the leadership of Dr. Sita, will be speaking about Gaza in the main conference as well. While our attention is focused on Gaza, there is another conflict that has been ongoing, one of the several conflicts that has been ongoing in Eastern Mediterranean region or Middle East region specifically, and that needs our attention. And in recent years, before in fact Gaza war, we saw that the attention was decreasing, and as a result, what we saw that the the attention of humanitarian and development community was also shifting in terms of reduction of resources, in terms of raising voice for that conflict. But with the Gaza war, I think it is again gaining attention. And now we have here a wonderful colleague, Dr. Arth Pesigan, who's the head of office and WHO representative in Yemen, another flashpoint of conflict in Middle East, who's going to give us an update from that flashpoint. Dr. Arth Pesigan is joining us early morning from Sana'a, Yemen. He was expected to be here and talk to you in person, but unfortunately because of the developments, again related to Gaza, and it is in one way or the other, fits well the Gaza conflict into the context of war, because there are so many other smaller and bigger fronts that are being opened or that has been revived in recent years, and Yemen is one of those. So, Dr. Arth, are you there?
Yes, Wasik, good morning.
Good morning, Dr. Arth. So, Dr. Arth, over to you.
Thank you very much. Thank you very much, Wasik, Professor Freiberg, and Dr. Veera Sakti. It's a pleasure to be here. And first and foremost, I'd like to acknowledge our thanks to the organizers for inviting WHO Yemen to join you this morning. First of all, also, I'd like to congratulate Professor Freiberg for a very good presentation and all of the commendable work of the Lancet Commission. And of course, to acknowledge the awesome work and the dedication of the UNRWA team for the efforts that they are putting into response for the Gaza situation. I would like to start off and let me share my screen for the presentation. So what I'm going to be covering would be first and foremost the overview of the situation in Yemen. Then I'm going to look into the efforts of WHO for the global health and peace initiative. Important approaches we are advocating right now, which is the humanitarian development and peace nexus. We will look into the priorities of the Yemen health sector, and then posit it with the approaches in terms of how major players like the health cluster and WHO are responding to the emergency and the shift to more development and also the peace building aspects. And of course, some sharing a bit on gender equality activities that the health sector is involved in, and capping it with challenges that we are facing in Yemen. So on this slide that I have right now is the Yemen situation overview. So it is, we just want to highlight that we have had 9-10 years of armed violence, a shattered economy, damaged infrastructure, and disruption of essential services, having left millions of Yemenis vulnerable to life-threatening risks and in urgent need of humanitarian support. And this is to be under the political situation of having like two governments in the country. Oh, excuse me, Wasik, can you hear me?
Yes, Dr. Arth, we can hear you and we can see your slides as well. Please continue.
Yeah, okay. So thank you. So we have here a snapshot that we have 17.8 million people that will need urgent health assistance in this year. And this comes from the HNO, which is the Humanitarian Needs Overview that has been coordinated by the UN OCHA. We have 16.9 million people suffering from acute food insecurity, 9 million people who cannot access clean water, and we know that around 12 million are in rural areas of the country. We have 2.7 million pregnant and lactating women in need of life-saving nutrition interventions. Nearly 50% of children under 5 suffer from moderate to severe stunting. And to support all of this, we only have 55% of health facilities functional or partially functional, with then 29% of functioning hospitals are without specialist doctors. So that is on the medical front. As we can see, let me move on to the next slide. I think I'm having a problem with okay, so continuing on the situation overview, we have two heat maps here. And on the left side is the one that I have just shared earlier in terms of the people in need over the years. And on the right side would be on the degree of the severity of that need, particularly for health. So in 2024, mentioned that approximately 17.8 million people will require health assistance, of which 3.2 million are internally displaced persons. From the 333 districts of the country, 71% have severe and extreme health needs. So as you can see on the right map, that the degree of redness in terms of the severity of health needs. Most vulnerable groups include, of course, children, women, elderly, individuals with disabilities and with mental health conditions, and marginalized communities and those affected by conflict-related injuries. 24% of people in need are women who require access to various medical and reproductive healthcare services, including 4% of pregnant women in need of emergency obstetric care. As mentioned earlier, also 50% are children requiring various levels of health support. And in addition to the chronic conditions, there are recurring outbreaks of cholera, measles, diphtheria, dengue fever, and polio. Now, moving on, so on the global level and also on the inputs of the WHO, there has been a greater interest and commitment by the organization, especially with the initiation of the Global Health and Peace Initiative, which is the GHPI. And it's been developed to address social determinants of health in fragile settings where people's health is negatively affected by factors such as conflict, displacement, marginalization, and poverty, which aggravate existing inequalities and vulnerabilities. So we're guided by having 6 work streams in GHPI, and I will not further elaborate on that. We have papers regarding this and references, but what we would want to do is also our aspiration that in the field level in Yemen, that we'll be able to contribute to these. But of course, on top of the overwhelming response that we have to do, we would want to at least document the efforts and also the situation in terms of health and peace. As I mentioned earlier, we are guided, especially now as we are transitioning, and hopefully the trend will be towards that aspect that we are transitioning for humanitarian to development. And we are guided by what we call the HDP, or the Humanitarian Development Peace Nexus. And we have here a very nice framework wherein we would want to be able to cover all of these aspects in terms of the work that we're doing. While we are addressing still humanitarian needs for the emergency part, we are also putting the building blocks in terms of development and, of course, building within the framework of peace building. So we would want to be able to look into improving gender equality, good health and well-being, reduce inequalities, promote universal health coverage, provide services like clean water and sanitation, and of course, within the framework also of human rights. Well, the government, and we would say like the 2 governments of Yemen are also expressing what their priorities are on health. And this is just like an overview. So the aspects that we would look into would be rehabilitating the damaged health facilities, starting with health facilities providing public health services, to address one of the immediate challenges precipitating the acute shortage of health staff by regularly paying salaries and providing adequate financial allocations for the ongoing health programs, to strengthen public health interventions such as prevention and control of communicable diseases, immunization against childhood preventable diseases, and emergency reproductive and maternal and child health interventions. Another priority is to build the capacity of local institutions and health staff to cope with the ongoing challenges linked with health services provision. Another priority is to provide a basic package of services at all feasible levels, community levels, to the mobile clinics, fixed primary healthcare facilities, and integrated outreach services. As I mentioned earlier too, aside from WHO, we have another very important player, and that is the health cluster. And we have also seen in one of the slides of Dr. Sita on the role of the health cluster in terms of response in Gaza. So here, from the emergency phase and continuing to development, the health cluster is playing a very important role in Yemen. So for this coming biennium 2023 to 2024, we could see here the continuum of activities. And as we can see here, it is not just looking into the emergency response, but already looking at strengthening of the health system, the kind of support that you can do in terms of area-based interventions for integrated activities for health, and moving down to strengthening supply chain and logistics, referral mechanisms, really building the health system towards development. And as we can see here, one of the aspirations of the health cluster will be to be able to link humanitarian efforts with development for peace building to maintain healthcare financing and sustain the health system, basically through the humanitarian development and peace nexus. Of course, WHO plays an important role in terms of the lead agency of the health cluster, but at the same time as the UN Specialized Agency for Health. So we are directing our efforts to be able to contribute to 2 of the 4 UN Sustainable Development Framework outcomes. And one is to enhance access to quality nutrition, resilient livelihoods and other areas, and to improve quality and access to social services. And we would say like one of our latest achievements is the development of the Yemen and WHO country cooperation strategy, which would be guiding our work for this biennium from 2024 to 2025. And our priorities are centered around evidence-based and innovative solutions for improved access to health services, including referral, with a focus on primary health care and community-based care. So we have 4 strategic priorities under this CCS. One is providing healthcare to promote universal health coverage with the focus on the most vulnerable. The second priority will be to protect the population by preparing for, detecting, responding to health emergencies. So that's still ongoing. As we can see also with the developments right now, we have to be on a heightened alert in terms of emergency response. Third priority is on promoting healthier lives well-being using a multi-sectoral approach to promote community health and address the determinants of health and risk factors. And an important strategic priority will be on promoting a health and peace dividend to support resilient communities and health systems and foster community engagement, equity, social cohesion, partnership, and collaboration. In terms of the work that we have done for the past 2 years, we have a listing here of some examples of achievements, particularly on the health services aspect. But what I would like to show on the right side is like linking and looking at parallels within the 6 building blocks of the health systems in terms of where are we in terms of addressing humanitarian response and how are we contributing or pitching in for development. I will just look into some examples. So on the building block on leadership and governance, so on the humanitarian side, on implementation at and through subnational levels in terms of activities, but at the development side, to work on being able to maintain leadership of local health officers. So that would mean a lot of capacity building and also development of policies in terms of governance. I'd like to give an example also on service delivery. So on the humanitarian side, we have been doing a lot of efforts in ensuring availability of basic services, like a blanket approach to ensure that we are supporting the provision of these services. But on the development side, investing in being able to have the concept and also a framework of minimum service packages referral to each level of care. So we're doing that for the various aspects of the 6 building blocks and bridging humanitarian and the development side. So other examples of WHO achievements in terms of a comprehensive approach in strengthening of the health system. So we have covered aspects on governance and leadership, on hospital care and management, building project management capacities of the Ministry of Public Health and Population, on information management, and also aspects of enhancing quality of care. A very important aspect of the work that we're doing, and we're very thankful for donors and partners, is that we've had the opportunity to be able to mainstream and to ensure activities to empower women, to strive for gender equality in all the interventions that we have. So I'd just like to cite these because these are very important aspects. Activities like training and awareness raising for partners and beneficiaries. So we have the figure of about 1,250 counterparts, health cluster partners, health workers, contractors, and consultants who have been sensitized and trained on gender-based violence, sexual exploitation and abuse, and sexual harassment, and how to deliver appropriate clinical care and psychosocial support to survivors, as well as on gender mainstreaming, gender-sensitive and gender-responsive services in health interventions to address inequalities within health systems. We have also continued advocacy and women empowerment within, knowing that we have increasingly difficult contexts for women facing various restrictions and limitations. WHO continues to promote gender equality considerations in various areas, like maintaining a 50% female participation in all supported activities. We're focusing on gender-sensitive services, so whenever WHO receives a gender-related GBV complaint from a health facility, we are communicating with relevant partners and authorities to urge them to maintain gender-sensitive services for beneficiaries and to work to protect the dignity of all beneficiaries. On the aspect of support to policymaking, we are liaising with the Ministry of Public Health and Population to work on updating national guidelines on health response to survivors of GBV based on established WHO guidelines and aligned with the cultural context. And the other aspect on close coordination with other partners, we are working well with UN Fund for Population to map GB services referral pathways for GBV survivors, supporting Yemeni women on situation analysis and developing standard operating procedures for women's protection. So what are the priority activities in terms of what we have mapped out for this year? So strengthen surveillance include case investigation at all levels, responding to outbreaks, from preparedness, the surveillance mechanism, laboratory support, response measures, while ensuring procurement of essential supplies for outbreak response, surveillance, and prevention. We will be supporting the deployment of mobile medical teams to enhance access to life-saving healthcare services to reach areas and camps, provide support to primary healthcare, and this is through our partners and also with the other similar agencies within the UN, conducting systematic nutrition status screenings and referrals for children under 5, delivering maternal and newborn care, especially on BMONC and CMONC, integrating NCDs into the health systems, building the capacity of healthcare workers to enhance their technical expertise, focusing on rapid response to identify, treat, and control evolving disease outbreaks, enhancing health information systems, and scaling up MHPSS, mental health and psychosocial support. Now, as you can see here, I probably did not elaborate much, but in all of these efforts and probably the most important part on peace building is that all of these efforts are being done with the northern governorates and the southern governorates of the country. And we always have a lot of technical discussions between the internationally recognized government and also the de facto authorities in being able to ensure that health is health for all Yemenis. So what are our ongoing challenges? The most difficult part, and I guess it goes across with all of the humanitarian crises that we're facing globally, is that there is a decreasing trend of humanitarian funding in Yemen. So a decrease of like more than 32% as of October of 2023. There is no lasting stability on the front lines, limiting partners' presence. We recognize the impact of reduced incentives for health workers, their availability, motivation in frontline, and hard-to-reach districts. So we are actually facing really the out-migration of the health workers. So further reduction in terms of your specialists, especially also your public health workers that will have to really serve the communities in need. Climate change further exaggerates the health impact, and we've seen the tropical cyclone that has devastated some of the governorates of Yemen in 2023. Still, with gaps in preparedness and readiness, lacking contingency plans, we're actually helping out in being able to strengthen, to review and to strengthen contingency plans, especially with the crisis in the Red Sea. Economic instability increases out-of-pocket expenditure, especially for vulnerable groups. Then we have to really look into the transition from humanitarian support to development through a strategy, capacity building. But then again, we're posed with this question, where are we here now because of the ongoing political tension around? And of course, the ongoing and also day-to-day bureaucratic processes and challenges that we face as we provide support to the ministries of health. So thank you very much to everyone, and I'd be very happy to respond to any questions, and would really appreciate comments and also your suggestions on how we can work things better in the health sector in Yemen. Thank you very much, and back to you, Asif.
Dr. R, thank you very much for your comprehensive presentation. All of us truly appreciate your commitment, waking up early in the morning and then doing this presentation and the wonderful work on sustaining and also building the system amid all these complex and difficult circumstances that you and partners are facing in Yemen. Any comments or questions for Dr. R related to Yemen's conflict and the work that has been done or is being done?
Maybe I take liberties
Yes,
asking whether WHO is supposed to do any conflict resolution, which is the root cause of, this or poverty and everything. Is the role of WHO in using health as a part of conflict resolution to solve the root cause problem?
I think in our own little way, we're contributing much on the technical aspects of work in terms of our sphere of influence. And because we're talking about health equity and also when you talk about gender equality, that in our day-to-day work, we have to ensure that it's one Yemen, and we don't make any distinction. And to be able to do that, we have to ensure that we bring like both sides in policy development, especially, and also in negotiation, that we will be able to provide the interventions, especially where they're most needed. So in that aspect, we are actively involved, but on the political side, perhaps, more of awareness on our side, more of advocacy that these are needed. But we basically look into the main health interventions that we can provide in support of the needs of the majority of the people of Yemen. I hope I was able to answer that question.
And Professor Veer, if I can build upon that response of Dr. R, if we look at it from three dimensions, one is the immediate intervention in terms of bringing peace, and that relates more to politics, and that limits WHO and other UN organizations' mandate capability to intervene meaningfully into it. But the second part is the systems part, and third part is the impact on the society part. The systems part, Dr. Arth has mentioned all the system building interventions in terms of the health force development, in terms of the provision of healthcare, in terms of the other psychosocial and social development and the well-being support that is being provided. But the third part that is related to mental health and the psychosocial support in terms of healing the trauma and also building peaceful societies. I think second and third part, the contribution is very well documented. But the first part, as I mentioned, the limitation of mandates and the limitation of politics, I think that limits not only WHO, but also other organizations as well. But that doesn't restrict us in terms of working on health as a bridge for peace. And that is why I give the credit to Dr. R that he's the first WHO representative who has brought in peace element categorically, visibly in WHO's engagement strategy with the country and with its people. That is what he has reflected in his presentation, which is called WHO Country Cooperation Strategy. Thank you.
Okay.
And probably just to add to what Wasik is saying, that's why we really appreciate the work of the Lancet Commission. We appreciate the GHPI framework of WHO, because at the field level, we have to feel that and we have to be guided on some of these elements. And it's not very simple. So we start off like with the conflict analysis and also having a certain framework and how we will be able to weave in all of those interventions that we have and appreciate that these are all contributing to peace building. Thank you.
Last intervention before we can go on break because we are limited by time.
Some comment from ladies? No.
Specifically,
ladies are more peaceful, they are quiet.
Yes, of course. Of course. We had another colleague joining Dr. R, Ms. Marcella from Cooperation Unit at German Embassy. Unfortunately, she couldn't join. In fact, she was expected to make an elaborate presentation on the gender aspect, the work that has been done and the work which is ongoing in terms of advancing gender equality in Yemen. Unfortunately, she's not here, but Dr. R did touch upon that work that is being done by WHO specifically. But she would have spoken more about the work of other partners as well. Dr. R, we wish we had more time, but thank you so much for joining early morning from Sana. We really appreciate the effort. Good luck to you for your wonderful work that you are doing, and we remain committed to supporting you in whatever capacity we have as academia, scientists, and the public health community at large. And we will be taking the message back home that Yemen is a crisis that shouldn't be forgotten. In fact, the needs are much more. The needs are higher now because of the crisis in Red Sea, and we need to continue to support you and other UN partners and other NGO and other development community that is working in Yemen. Thank you so much. Thank you.
Thank you
An
very
appreciation
much.
from all of us from
Have a
here.
good day.
Yeah, thank you. So with this, colleagues, we will be taking a 15 minutes break. We will go for coffee now outside this room, and we will come back, and then we will continue with the other interventions. 15 minutes. 15 minutes. 1-5. Thank you very much.
discuss the Prince Mahidol Award Conference. I wish I could join you in person. However, due to the ongoing executive board of WHO, I have to be in Geneva. Dear Excellencies, colleagues, ladies and gentlemen, I am delighted to be part of this important discussion on using health as a bridge for peace. The ongoing conflicts in WHO's Eastern Mediterranean region, such as the situation in the occupied Palestinian territory and the resultant suffering, underscore the critical relevance of this topic to the region and the world at large. And Southwest Asia. The WHO Regional Office initiated a Health for Peace initiative in 2019. The initiative was inspired from the experiences of Central American countries, where the concept of health as a bridge for peace was successfully employed during the 1980s and the 1990s. In our region, the unfortunate reality is that conflict has become the new normal. Multiple countries have endured prolonged conflicts, and the emergence of new conflicts remains a persistent threat. Since 2014, the region has borne the brunt of global conflict-related fatalities, with an alarming toll exceeding 150,000 deaths annually. Moreover, our region hosts the world's largest population of refugees.
Welcome back, everyone. Welcome, everyone. So I hope all of you present in this room had a wonderful break. So we had the opportunity in the morning before break session to hear from several speakers, including Professor Freiberg on the Lancet Commission's awareness exercise on the role of health and gender as powerful drivers for peaceful societies, building and sustaining peaceful societies, followed by interventions by Dr. Kirosita from the ongoing conflict in Gaza, and then another ongoing conflict in Yemen that has been discussed and presented by Dr. R. Pesikan as well. So we move on now, and we have another wonderful colleague who has been working in conflict zones for a while, but in a different region. If you can solve this, yeah, thank you very much. So from Europe, we take the perspective of Europe, and Dr. Guillaume Simonian is joining us from Bulgaria, where he is currently based. He has recently moved from Ukraine to Bulgaria as the WHO representative, but Guillaume has been a health and humanitarian worker for a while, and he has done wonderful work. He was, in fact, one of the main architects of WHO's health and peace initiative at global level, and then he later went back to field and did some wonderful work in Russia-Ukraine conflict. Guillaume, are you online? Guillaume, can you hear me? Can someone check if Dr. Guillaume is online? I think he was online previously.
Good morning, Wasik.
Good morning, Guillaume. Can you hear me?
Right. No, yes, but just before when you were speaking, I couldn't hear you well.
Okay, so we were saying all good things about you. Thank you so much, Guillaume, for joining.
Thank you, thank you.
Wonderful. Guillaume, the screen, floor, and the audience are yours. Go ahead.
Very well. Let me try to share my screen so that I can put the presentation online. How do I do that? There you go. There we go. Do you see my screen, Wasik?
Yes, Guillaume. If you can put it on presentation mode.
We try. There we go. Right?
Yes, it's coming up.
Yes.
Yes, go ahead.
Very well, very well. So good morning, colleagues, and thanks for the WHO Emerald Regional Office and for WASIC in particular for organizing this session. It is very important indeed that we cover this topic on how health can bring peace and trust dividends. And here I will present in this session what we call healthy trust in Ukraine. And the experiences that we have since before the war escalation and currently during the large-scale, full-scale war that we have in Ukraine. So a bit of a background. So there has been no census in Ukraine for the last 20 years, and hence we have quite a wide range of estimations in terms of people. In between 35 and 43 million live on Ukraine, but what is sure is that Ukraine is the largest territory in Europe. We have a quite long conflict history. In 2014, a large part of the territory was not under the control of the government, with an initial war starting with a part annexed by the Russian Federation and a part not controlled by the government. Ukraine is a context that is extremely dense, geopolitically speaking, with a multitude of geopolitical interests which are intertwining in this conflict. And since the 24th of February 22, a full-scale war that started with the Russian Federation invasion. It's a context of large structural issues, numerous structural issues. So the environment is very politicized, and we have a number of political dynamics which are playing on trust. So people who are nostalgic of the Soviet era versus people who want to move towards something else, which we call here the Soviets versus the moderns. Western Ukraine, Eastern Ukraine, which has different orientations, plus the main language, Ukrainian versus Russian. Politics which are heavily persona-based, so political parties based on the leader of this party, which is bringing a wider coalition, and the media environment, which is also very politicized. And we have a lot of other politicizing elements in the environment. We have, since the last 15 years already, a reform aiming towards decentralization, which is quite effective, and the local authorities having a lot of autonomy. But at the same time, since the full-scale war, martial law, which is centralizing the decision-making, and these two dynamics come together and also work together and sometimes contradict each other. We have constitutional guarantees of free unlimited healthcare, but it's not working in real life, and we have one of the highest out-of-pocket payments rates in the whole region of Europe, and in some of the highest rates in the world as well. The national budget as well, the whole of the domestic resources are going to the army, and all social expenditures, including health, is totally dependent on external aid and on out-of-pocket payments for what concerns health. We have a workforce which is highly qualified but underpaid, and we have a hospital infrastructure which is very numerous, which one can say excessive, which also is costing a lot to maintain. So what we had as WHO prior to the war escalation, so we had two dynamics of health and peace, one which we supported the social cohesion by work in the communities, by doing dialogues, trust building between the institutions, the practitioners, and the citizens, to promote the reform, including in the conflict affected areas. We also worked on supporting essential health services and systems, especially in the conflict area, and trying to provide the best possible care to all civilian victims. And we also already worked on mental health, which was already prior to the war quite a significant issue. And then we had a second element of health and peace work, which was to use health as a mediation factor to promote dialogue across the conflict lines. So we had with HIV, AIDS, and TB an exchange of information between the two sides, the non-governmental controlled areas and the governmental controlled areas, around IHR and surveillance issues. Same thing, we are playing as a mediator to ensure that threats which don't know any border or don't know any conflict line are understood on each side, and that information is flowing on each side. We worked on ethics promotion within the armed forces, both from the armed groups and from the regular army of Ukraine. And we worked at health standard promotion, and having some of the health days being hailed in all through the territory of Ukraine, non-controlled by the government and controlled by the government. So that was our program prior to the war. After the war, we revised the understanding of what healthy trusts can be in Ukraine. Because of course, with a full-scale war, the context had changed. One element that's maintained, and here we can praise the resilience of the health leadership, is the health reform, which remains throughout, before, during the conflict. I will explain a few dynamics of mistrust that exist currently in Ukraine. The specifics of mental health and rehabilitation, which can be both social stressor but also trust builders. We take it from this angle. And then I will explain the programming that we have at the moment. So the health reforms, to explain it, the health system of Ukraine went from the so-called Semashko system, which is a system that matches various severity of diseases to 5 administrative level of care, so from national to municipal, but which had a very underdeveloped primary health care, which was often skipped to get straight to specialized care. So it's a system that can be efficient. There is no perfect or wrong system, but which is costing a lot to the national budget, which worked during the communist time, but at independence, it couldn't be afforded anymore. And since 2013, so just before the first war started, Ukraine has moved towards a capitation-based single-payer architecture, which creates a national competition amongst healthcare providers based on the efficiency and need for a service, with primary healthcare as a gatekeeper to the whole system. So it's a complete paradigm shift from one organization of system, Semashko, to capitation-based system. So this reform, which is matched with other areas of reform, is very ambitious. At the same time, it's questioning significant paradigms which have been culturally enshrined in what concerns healthcare in Ukraine. And this, since last year, so since the second year of the war, a Health 2030 strategy was composed, which is battling with lots of conspiracy theories, which is, one can say, a natural thing when cultural paradigms are being questioned for more efficiency and optimization of healthcare. It comes together with lots of difficulties to move society towards a better care, and the Health 2030 strategy is working on that. So mistrust in the health sector. So we have quite a significant popular mistrust towards the health sector. So back a few years in time, the pandemic of COVID-19 highlighted several deficiencies, so underlying deficiencies which came to the front and which created quite a lot of dissatisfaction with society. Although Ukraine managed quite well, I have to say, the COVID-19 pandemic, with very quick reorganization of the system to provide efficient care to respiratory diseases. But still, a lot of the underlying deficiencies came to the front, and it compounded some grievances which the reform had initiated and which came further to the front. The lack of popular trust towards institution is not only for healthcare but at large, and it affects health institutions as well. The understanding of the reform and the aim of the reform of what is primary health care, what is a health service, and how optimization is being managed is not well understood through the population. and the dynamic of decentralization coming on top of that, which is also something that the society has to learn. Corruption, so it's not to be hidden that there is a significant level of corruption, which is also a barrier to trust. The constitution is giving a right of all Ukrainians for free healthcare, but the reality is different, and the pay of the doctors and the nurses and the healthcare workers being so low, a large part of their revenues come from actual out-of-pocket payments, which goes in contradiction with what the constitution is saying. And then remnants of the Soviet system, which is not that long back ago, both physical with those large number of facilities I mentioned at the beginning, and also cultural in terms of what the society is expecting. Between professionals, so the several institutions like the single payer institution, the National Health Service of Ukraine, are very new and didn't have the time yet in the short span of existence to generate trust towards the clinicians, which perceive the NHSU as they don't know what we need, they are economists who are clinicians. The politicians, which some play on this trust towards the next elections. Some also do the easy blame, knowing that this mistrust exists, blame the institutions, either the hospitals or the NHSU. And it creates like a triad of mistrust between clinicians, administrators, and politicians, which is not a fatality, and on which we are working on through facilitated dialogues and to ensure that all parts of society engaged in healthcare work together. Then speaking of rehab and mental health, so Ukraine has a very large army. There is very heavy fighting ongoing all throughout the front line, which is one of the longest in the whole world. And on top of rehab of the civilian population, if you have a stroke or a fall or an accident, those events don't stop with a full-scale war, which creates a huge increase in terms of the rehabilitation need for acute and subacute care, but also for general rehab. And the estimate from the Ministry of Health is that each and every year, a minimum of 80,000 patient beds are required to provide the necessary care for the population, while the baseline before the escalation was 5,000. So you see like the huge increase that is required. And the WHO is working very hard together with the Ministry of Health, the presidential administration, and many institutions to ensure that this scale-up is a reality, and we are already halfway through it. And as well, mental health. So the war is creating a mental health issue all throughout society. So for the people on the front line, which are seeing death on a daily basis, to the families of the soldiers, to the civilians, which are also affected to a big scale, and then all of the reality of war, of having to go up and down to the basement, having to have school in a bunker, and the list goes on. So it creates lots of mental health also in society. And then the big issue of reintegration of demobilized soldiers. So there is no full-scale demobilization in Ukraine, of course, because the country is at war. But we have lots of demobilized soldiers for different reasons, oftentimes because of injuries at this stage. And as any war, it will not last forever. We have to think of the next steps when more than 1 million people will have to be demobilized. And this reintegration will be a huge undertaking, which will have a lot of NHPSS component to it. So in this context of rehab and mental health, if the health sector is misperforming towards the needs for rehab, towards the needs for mental health and psychosocial support, it can be a cause for massive implosion all throughout society. But if you take it from the other angle, and that's the angle that we take as WHO, if the health sector is performing well, then it can be also a reason for hope and trust. And we see lots of examples of that at the moment. So how we shaped as WHO our healthy trust theory of change. So we are on the if side. So if the society develops action plans, develops the common future that each want for their own healthcare system together through participatory health methods, and by looking at what peace and resilience can be, so having an objective analysis of what is the desire of the society. If the key drivers of mistrust, and I mentioned some of those in the presentation, are addressed by all stakeholders, not only at national level, but also in the regions and in the cities. If we build capacities to national and regional actors to promote good practices and to undertake this participatory process that I mentioned, and if positive information campaigns are carried out to make understand the desires and the vision. If local solutions around health service delivery are implemented, and if out of all of that, evidence and good practices are collected, generated, and disseminated, then we move to the outcomes level. We will have improved access to healthcare services, both real and perceived. And the perception is also important in this context of reforms, mistrust, and war. Then we will have better trust between the state institutions and the population. And then, which is also important for WASIC and for you in the room, the lessons learned from this program and from Ukraine can contribute also to the global health and peace agenda. And as an impact, that's the second then that we have here, the health service delivery also contributes not only to the health outcomes, but also to building and rebuilding a strong, resilient Ukrainian social contract between the state and the population, which will stay during and after the war, when the peace from the political side will be a reality. There is a number of assumptions, because we have some barriers, some budgetary issues, and here the global support to Ukraine is extremely important. As I mentioned in the slide on budget, 100% of the health expenditures in Ukraine are coming from external aid at the moment. The problem-solving processes have to be embracing all stakeholders to take relevant decisions. The authorities must keep motivated. They are at the moment, and they must keep motivated to respond to issues by the patients. So when grievances are coming to the front in those participatory efforts that we do, authorities must be ready to respond to them. And we don't have other barriers coming through. It can be funding, it can be further escalation of the conflict. So that's what I wanted to present in this short talk this morning. I thank you very much for your attention, and I wish you a very good meeting and ready to respond to questions. Thank you.
Thank you very much. Thank you very much for giving us an overview of the work that you have done in Ukraine, and now your other colleagues are carrying it forward. Questions and comments for Guillaume from the audience here? Guillaume, while other colleagues are thinking about the work, the questions, one question related to your documentation of your work. a lot of work, as I can understand, a lot of work has been done in terms of developing a robust conflict analysis in Ukraine, thanks to your leadership and your work. But when you started implementing your interventions, have you been able to document it? Have you been able to document it in a way that other programs can learn from that perspective as well? Any quick reflections on that?
Yes, thank you, Wasik. Yes, we have tried indeed. There are several rounds of documentation. So prior to COVID, we had done a lot of work to document, in particular, the work on mental health and psychosocial support. One work that we could not, however, document is a work on mediation between the conflict lines, because this work was done under the premise of confidentiality arrangement with the armed groups and with the government of Ukraine. So all parties were in agreement that we support in this field, but under the premise of full confidentiality. So we could not document this work, and we will not. During COVID time, the work on health and trust was heavily documented as well. So we have a very good report that was produced by Interpeace, documenting all of the work that we did during COVID. And we also did an external evaluation, which is also a way to document this work that external evaluators have done. During the war, we are still too deep into it, and we are at this stage, at the new proposal stage, to raise new funding. So in the proposal, we have documented what was done in the first year of the war, but it's still too fresh to document dividends at this stage during the war escalation. So in short, yes, at different stages in the makeshift of this program.
Thank you very much, Guillaume. And it is very useful, as I said, for this community to be aware of that work so that we can learn from it and replicate the lessons learned in other contexts as well. Another piece of work that you must be aware of in terms of Russia-Ukraine conflict context is this online course that has been adopted, and hundreds of workers have completed, health and humanitarian workers have completed. It was done by an NGO, and our headquarters team in Geneva worked with them in terms of adaptation of that course. Questions, comments for Guillaume? Yes, please. If you can introduce yourself and also ask the question.
Hi, thank you for the presentation. I'm Saudamini from Thailand. You explained or shared the trust framework that you utilize, and by its nature, building trust is a long-term process. So could you comment or elaborate a bit more on what are some of the elements that you're putting in place, either as WHO or in conjunction with other partners, whether it's governments or other actors in the conflict zones? If you could share a few thoughts.
Guillaume?
Sure. Yeah, thank you. Thank you for the good question. So yes, so what we have worked with the government of Ukraine, so all revolves around the Health 2030 strategy, which was designed by the national government in conjunction with national institutions and with some of the regions. So there have been different stages. So the first stage of this trust building was to engage as much as possible the regions into the design of this Health 2030 strategy, and to provide this feedback to the leadership of the Ministry of Health to reshape some of the elements of the strategy so that they play on building trust. And then what we did prior to the war escalation, and that we plan to restart doing now that some regions have been stabilized, is to walk through. So if you know the WHO strategizing health flagship guidance, there is one chapter which is linked to participation of society. So what we aim to do at this stage is to walk through essentially participatory dialogues with specific professions involved in healthcare to capture the requirements from the profession itself. We have started with the nurses, and each and every month we are serving the requirements of the nurses of Ukraine, bringing representative samples of nurses together to speak through this topic, feedback to the ministry on what the nurses of Ukraine require, need, sometimes grieve about, and the ministry, to take this specific topic, is currently designing a nursing 2030 strategy, which is like the specifics of the nursing component of the strategy, which takes this participatory dialogue with all of the nurses of Ukraine into account to build it in a way that matches the requirement of the nurses of the country. And we try to do that with different professionals of healthcare to capture the needs and trust element of the profession. Then we also organize triangulated dialogue between the health economists of the National Health Service of Ukraine and the clinicians, because these two communities don't have the same expectation at all. And we work as a mediator, as WHO, between the requirements of these two sides by organizing regular dialogues between them. And then with the population to ensure that the needs and perceived issues by the population are collected, get to the political level, and at the political level that we design policies, campaigns, and efforts to address some of these issues which are real, and to communicate on the perceived issues towards better understanding of what the reforms are. So in a short summary, that's what we are trying to do to ensure that the issues of mistrust turn towards issues of trust. Over.
Thanks, Guillaume. And building upon it, another good example of trust is trust intervention in terms of sustaining or building peace in Somalia. And Guillaume was part of that intervention when we designed it. This project has been implemented in Somalia for a while now, and WHO was the main driver of that project. But the bulk of this work has been carried forward by NGOs. I wish we had the representative of Somalia who could come to Bangkok and share that. But the focus of the intervention of the type of intervention of mental health and psychosocial support, the focus of intervention was young people. How youth can be mobilized to create and sustain peace, particularly in different regions of Somalia, which have, and Somalian conflict has a different dimension. But a large number of youth were trained to be advocates of enhancing trust among the society, among themselves, among the society, and making a contribution towards sustaining peace. Any other comments or questions for Guillaume? Yes, Espen?
Thank you. I can see when there will be peace, when the war is over in Ukraine, I can see that if you improve the health system, you can create trust among people. And if you create trust in one system, the health system, you will create trust in other systems in the country. But can you see that, is it possible to create trust into the health system during the war? We see that a lot of people are leaving the country, millions, to neighboring countries. Can you build the trust during war?
Guillaume?
Yeah, it's a good question. That's indeed what we are trying to do. But there are different ways to that, because as you say, there is a large span of the population of Ukraine has left the country by fear for their personal safety and for the safety of their children. So we are working on that, on portraying, projecting a health system that delivers, which is true. The health system of Ukraine has been formidably resilient, and there has never been at any point during this war a full crumbling of the health system, and quite the contrary, it remains and it thrives. And we are also working in the neighboring countries with our colleagues. Now I'm the representative in Bulgaria, and the Ukrainian population living in Bulgaria. We work with them, passing also the message that at home the situation with the health system is resilient, and there is no fear to have regarding the type of care that you can have if you get back home. At the same time, providing care to them in the country where they reside, in Bulgaria for this, for me, but Czech Republic, Poland, etc. There are many Ukrainians having left across the border. And inside of the country, we are continuing this work that I mentioned regarding triangulated trust between the population, practitioners, policymakers. And on top of that, that's why I mentioned rehabilitation and mental health. We are significantly expanding the care possibilities in these two areas. On rehab, creating a workforce which is really capable to better take care of the general rehab needs, and also to take care of the acute needs for trauma, limb injury, brain injury, spinal cord injury. So all of the conflict-specific rehabilitation case. And on mental health, we have designed together with the government a very, very comprehensive program, which looks into taking care of the population for common pathology at primary health care, with a very ambitious program of having trained and certified in MHCAP all of the primary healthcare workers of Ukraine, which is about 200,000 people, with developing a system of mental health outreach to populations which didn't exist prior to the war, and for which now we have over 100 teams which are providing outpatient care for acute mental health conditions. And at the same time, designing for what we call community care centers, which also were not existing prior to the war, all throughout the territory of Ukraine, and doing also a wide campaign. It's called TIAC, which means How Are You?, which is widely promoted all across society, which lots of relays everywhere you go, to also make each and every Ukrainian understand that this war is having an impact on him or herself, but he or she is not alone, and the whole of society and the whole of the healthcare system is with them. So it's just a few examples to explain on, we are very cognizant of the need for working now on what will be after, when there will be peace, and that it is important for the social contract of the society at large in Ukraine. And we're doing our best.
Guillaume, thank you very much. Last intervention from Peter, and then we can conclude because of the time.
Thank you. Thank you very much, Guillaume, for your taking your time and to present for us. I'm just wondering, I mean, speaking also about what Espen brought up with trust that can spill over to other systems, not just health. I'm just wondering about, education. Education is also something fundamental in the society that builds also trust. Is it possible to sustain education at different levels in Ukraine, and which would be some important investment for the future? Thank you.
Guillaume, if you can briefly comment on it so that we can move on. Guillaume?
I didn't hear the end. I heard the issue of education and then it was muddled. Yeah, I couldn't hear.
If I can understand well, Peter, how do you see the potential of education as contributing to peace building in the long term in the specific conflict that you are working on? And if something has been done in this context?
Right, okay. So there is specialized education. So as WHO, our mandate is on health. So when we work on higher education, that's about the medical professions. So here what we do, because we see indeed that there are in fact compounding issues. The future medical students of Ukraine will have lived through 2 years of COVID, which was only online courses, and then 2 years of war. And if the medical university doesn't have a bunker, then it's also online. So out of 6 years of university, so far, 4 of them, for those who entered the system in 2020, have been online. And for a future medical doctor, not having had this interaction, this practice, and this physical practice of medicine throughout pretty much the whole cursus is a potential issue that we are working on with the Ministry of Health. One of the activities that we do here is to provide, because there is a lack of healthcare workers in the facilities. So doing early internship to students to allow them to have some interaction at least with patients, which at the same time is also providing support to the facilities which go to a health workforce crisis at the moment. Some professions like epidemiologists, like anesthesiologists, we know that there will be a gap because of several reasons. One of them being that many of them have left the country or left the region to go to more peaceful regions. And here we are working more specifically with the regions affected to look with them at what incentives can be put in place to ensure that the region is in some way attractive still for the students of their universities or the universities of the cities nearby. And we are also working at capturing the whole needs for the health system. So we are deploying the tool of health labor market analysis, which is essentially looking at what the current labor is. So according to the WHO standards and the national standards of care, against the needs of the population, and doing the matchmaking between areas where there are gaps and the technical assistance to these specific professions, including in education, and areas where there is sufficient space to also promote towards society that sometimes the perceived lack of healthcare workers is only perceived. Then if you turn to general education, so here we are more working towards the image PSS effort that we do, which includes non-health psychosocial intervention in non-health sector, and education being one of them.
Thank you very much, Guillaume. So one of the aspects that needs to be emphasized here in such examples is that since each conflict is different, and when we are doing the conflict analysis, we need to look at the drivers and the opportunities that we have. But at the same time, we will have to look at the limitations of those organizations which are doing these interventions. For example, for WHO, there are certain limitations of mandate, certain limitations of politics, certain limitations of of governance mechanisms that it has. So we have two choices as organizations. Either we work within these limitations and deliver on those objectives which we are required to do, or we don't do that. So organizations like WHO and others, they choose to do the action, but within the limitations. That sometimes puzzles students like us and the professionals like us, that why they are not directly addressing the issue because of those limitations. And it is critically important to understand those limitations. Russia-Ukraine conflict is an international conflict. It is not a localized conflict. It has implications not only on the immediate region, but it has international implications as well. Similar with the Gaza conflict, that it's a global conflict at the moment because of so many other dimensions it has. So those organizations which are working there, whether it is UNRWA, whether it is WHO or NGOs, they have to work within the sphere of limitations they have. But interventions, their goals, and the pathways towards peace, that needs to be understood from sometimes not in a directional way, but sometimes we have to look at it from a holistic perspective to fully understand the context and the impact of that delivery. Guillaume, thank you very much. Wonderful to have you, and thank you so much early morning joining from Bulgaria. We should appreciate Guillaume's
Thank you, Essex, thank you, colleagues.
Thanks very much. We will move on to our last speaker of the session. Last speaker of the session also wishes if he could have been here, is the WHO Regional Director, Dr. Ahmad Al-Mandari of WHO Regional Office for the Eastern Mediterranean region, but he has sent us a recorded message, and we will play that message, and then we will move on to the concluding remarks and the conclusion of this session. So if you can please play that recorded message. The second video.
Thank you, Professor Peter, for inviting me to address the Prince Mahidol Award Conference. I wish I could join you in person.
Can you please start from the beginning?
Due to the ongoing executive board
and raise the volume.
Thank you, Professor Peter, for inviting me to address the Prince Mahidol Award Conference. I wish I could join you in person. However, due to the ongoing executive board of WHO, I have to be in Geneva. Dear Excellencies, colleagues, ladies and gentlemen, I am delighted to be part of this important discussion on using health as a bridge for peace. The ongoing conflicts in WHO's Eastern Mediterranean region, such as the situation in the occupied Palestinian territory and the resultant suffering, underscore the critical relevance of this topic to the region and the world at large. In the Eastern Mediterranean region, which encompasses nations from the Middle East, North Africa, and Southwest Asia, the WHO Regional Office initiated a Health for Peace initiative in 2019. The initiative was inspired from the experiences of Central American countries, where the concept of health as a bridge for peace was successfully employed during the 1980s and the 1990s. In our region, the unfortunate reality is that conflict has become the new normal. Multiple countries have endured prolonged conflicts, and the emergence of new conflicts remains a persistent threat. Since 2014, the region has borne the brunt of global conflict-related fatalities, with an alarming toll exceeding 150,000 deaths annually. Moreover, our region hosts the world's largest population of refugees, internally displaced persons, and migrants. This poses formidable challenges in providing essential services, accommodation, and social protection. The situation has been exacerbated by the compounding effects of the COVID-19 pandemic and its accompanying economic hardships. Dear colleagues, when we launched the Health for Peace initiative, we had three primary motivations. Firstly, we recognized that unless we address the impact of conflict and the absence of peace as determinants of health, attaining our primary goal of achieving health for all by all would remain elusive. Secondly, while acknowledging that we as health and humanitarian practitioners are not politicians, we recognize the profound influence of politics on our work. We understood that speaking the language of peace was needed to garner support from policymakers and influential figures. Thirdly, drawing inspiration from examples in Central American countries and other places, we believed in the transformative power of health as a bridge for peace. Instances such as ceasefires for immunization, witnessed in the past, were seen as initial steps toward peace building. Our initiative named HOPE, Health for Peace, was accordingly built upon three pillars: delivering health services in underserved areas, which contributes to the promotion of peace and trust; creating a platform for dialogue, recognizing that the health sector can provide a neutral ground on which to bring together health professionals from opposing groups to address mutual health; and promoting mental health and psychosocial support, acknowledging the importance of overcoming the psychological scars of conflict. To translate our ambition of health for peace into action, we took a multifaceted approach, encompassing advocacy, evidence generation, training for health workers and managers, and fostering partnerships. The initiative received vital support from Oman and Switzerland. The initiative has yielded commendable results, some of which I would like to highlight. Firstly, while peace and health are linked in WHO's constitution, there was no clear operational approach at the global level. Thanks to the momentum generated by our regional initiative, WHO has now developed a global roadmap on health and peace. Moreover, thanks to Professor Peter and esteemed commissioners, the collaboration with the Lancet Commission on Peaceful Societies through health equity and gender equality has significantly improved the evidence base by providing global evidence and practical recommendations on how health can contribute to peace. The initiative has undertaken capacity building at a global level, promoting a shared understanding of its importance and how it can be practically implemented in the field. One of our courses has been completed by over 17,000 health and humanitarian professionals worldwide, and subsequently adapted to train health workers in conflict zones in the Russian Federation and Ukraine. And our country offices have played a crucial role in incorporating conflict-sensitive health programming into their activities in conflict-affected areas. Notably, several countries in our region have established robust programs focusing on mental health and psychosocial support. Ladies and gentlemen, the Health for Peace initiative may not have directly resulted in peace, but the progress made in revitalizing a dormant field is significant and much needed in today's world. The initiative has laid the groundwork. During implementation of the HOPE initiative, we have learned that taking a holistic approach is essential, both in the design and in the implementation of projects on health as bridge for peace. This insight accords with recent findings from the Lancet Commission on Peaceful Societies. In countries affected by conflict, health actors must embrace peace as a core goal if they are to realize the vision of universal health coverage and other global health objectives. Even though our focus is on healthcare delivery, we need to understand the drivers of conflict if we are to meet the healthcare needs of individuals in conflict-affected countries. It is imperative that we in the health community express our belief that there is no health without peace. Advocacy for this is needed, particularly by influential countries, individuals, and groups. I believe that the unprecedented scale of attacks on healthcare during the current conflict in the occupied Palestinian territory underscore the urgency of such initiatives. Such assaults not only jeopardize the lives and well-being of individual patients and health workers, but pose a direct threat to the functioning of the health sector itself. Our collective commitment is required to counter such attacks. We believe that using health as a bridge for peace provides us with a visionary approach that not only helps us to fulfill our mandate of securing health for all, but can also contribute to building peace in conflict-affected regions and protecting the essential work of the health and humanitarian communities. Thank you for the invitation, and I wish you all productive and impactful discussions in Bangkok.
Thank you, everyone. Thank you, everyone. I'll emphasize 2-3 points that are coming out clearly. There is no escape for health community or public health community from discussion and interventions on peace. Peace is political. It will remain political. Peace building, sustaining peace. But for health to achieve its objectives, for sustainable development goals, health community, public health community has to talk about peace and do something about peace as well. That it is a realization that is growing among public health community. Now, public health community is very fond of, and it should be fond of, building and designing its interventions on evidence. And evidence around health as a bridge for peace is slowly and gradually building. The other important thing is we do recognize that while this evidence is building, we cannot wait for the evidence to be made available and then we do intervene. We have to intervene as public health community. But how do we intervene matters. How do we design conflict-sensitive programs in conflict-affected countries? How do we design programs that do not immediately serve the immediate needs, but also have long-term impact in terms of healing the scars of conflict, scars of decades-long wars, and the war zones that these people, the immediate beneficiaries of health interventions, live and are going to live for the rest of their lives. Now, 4 key messages that are also coming out in terms of the work that can be carried forward. One is evidence is critically important. More and more as a public health community, we need to work on it. And when we say evidence, these are not randomized controlled trials. All practices, all experiences, all what we do in our field, that is evidence, but it needs to be documented. It needs to be shared widely, and it needs to be improved with the passage of time also. That's why I was mentioning to Guillaume, have you documented it? The reason is, I know that that is documented, but the reason is those who are interested in taking the advance, the science of this work forward, they need to look at that evidence. And when they are doing this work, they need to share it with others as well, because the conflicts are not only restricted to certain countries, there are possibilities, and as Dr. Ahmed mentioned, a persistent threat of newer conflicts appearing in different parts of the world is very high. So evidence is an extremely important priority to take forward as a result of this discussion. The second part is advocacy. Advocacy in 2 dimensions. One, as health and humanitarian workers, talking about peace is critically important. Peace is not an alien subject for health community. We should speak about it. And we should say that in order for us to achieve the universal health coverage, in order for us to achieve the health objectives that are being given to us as a mandate, peace is necessary. And if peace is necessary, we have to have our contribution, and we have to have a position around it. And that is why embracing peace as our part of our rhetoric and our work and our action is critically important. The third part is relatively easier, has been done and is being done and should be done, is making peace as part of the health programming that we do in our conflict-affected countries. The last part is building skills around peace. Like, skills are critically important for public health objectives to be served, but peace is also a field that we need to learn about. How do we communicate? How do we negotiate in difficult situations? Those are different skills, and we need to orient ourselves as public health community and humanitarian community around it as well. And for those who are interested in it, there is a course that has been developed, an initial course that has been developed online, freely accessible, available for people. As Dr. Ahmed mentioned, thousands of people have completed it also. It is being used in different conflict zones. We encourage you to take it forward as well, and also promote that course. It is openly available on openwho.org, which is an open WHO platform that can be accessed by anyone having internet access. With this, let me invite Professor Freiberg first, and then Professor Veer for concluding remarks. Professor Peter first.
Thank you so much, Vasik, and thank you everyone for being here and have spent time and learned about these various conflicts. I just want to say that, emphasize again that conflicts are not the same. They are very different. And we need to take into account what kind of context and situation people are in various conflicts. It's also that crises don't go just in silos. So, for example, in your region, Vasik, you have also problems, that was mentioned also in some of the presentations, with extreme heat and with the climate change going on as well, drought, lack of water and so on. So with temperatures rising towards almost 50 degrees Celsius sometimes, together with conflicts, I think we need also to consider that several things must be handled at the same time, and involving also different areas of expertise and action-oriented people. So, I mean, some populations and people are really put at risk and suffering, not only for conflicts and war, but also of other things like climate change as well. So we need to do these things together, and several ministries, several organizations need to work in tandem in order to try to bring peace and fight and tackle also other challenges in this kind of friction of time that we are seeing now. But these kind of meetings and sessions with including both academics and also people from the ground, I think they are key, and we need to continue these discussions. And I'm very thankful to you, Vasik, and the MRO, and also for organizing several people to speak and to put forward this kind of difficult messages as well. But we need to never give up and just to continue. Thank you.
Thanks very much for organizing several expertise especially in the humanitarian and health development. Before we think in war, we have only humanitarian actions, but nowadays you also have health development together. So public health is now becoming important in the conflict areas. We have heard different areas like in Gaza. We see that there's a major political restrictions that make the humanitarian need not met, acute humanitarian need being obstructed by these geopolitical conflicts. We see from the Yemen that the conflict is not in a very high tone, but there's still a lot of need to help the underprivileged peoples. And we hear from the Ukraine examples that we have to build trust and improve the health, financial security systems for the country. Even there's in wars. And we heard from Emerald and about the help us with peace. These are all very experienced people that are very useful for us, the host in Southeast Asia. But in the afternoon, we have a lot of young people who speak in the other form, more on the preventive aspect of before engaging into this very sad. I feel a little bit depressed after listening to a series of a lot of desperate conditions, but have very great admire to your people work in these constraints. So in the afternoon, we hope we can continue at 1 o'clock, looking at what is Southeast Asia doing and in country conflicts and the geopolitical conflict between the regions, the East-West, China and Western superpower, which Southeast Asia is being sandwiched. So we hope to see you again at 1 o'clock.
Can I?
Please.
Yes, and I think that's what you put forward with the young perspective is very important. But I also want to thank you, sorry I forgot about that, to provide all the with the equipment and also the planning for this meeting as well from your point of view and your team. Thank you.
Sure. Thank you very much, Professor Veer and Professor Peter. So, colleagues, we will be going into the next session as at 1 o'clock, as Professor Veer mentioned. But a reminder, the copy of the Lancet Commission report is outside available. Please do take it. A lot of good things are there in terms of the evidence. There is another main conference session that is coming up on 26th of January at 10:30. That is also going to discuss conflict and a bit of this element what we have discussed in detail today. So please do join us. Several other speakers, including Asman, will be there, and they will be speaking, and Professor Peter will be moderating that. A lot of gratitude to Professor Veer, Peter mentioned, but also the team that is back there and who has been managing technology, and especially those who have been putting this together, including Milen, June, and also our wonderful colleague Brigitte, who came all the way to help us with this. We will be, we will have, I think it would be great if we can have a photo at the end, so that this session can be concluded and we take a break and then come back to the next session. So if everyone can come here and we can take a big happy family photo, and then we can conclude this. And
to be quick, we post this way.
Yes, yes. Thank you very much. Please come on stage and we can have a photo. Thank you very much.
You just sit and then we go down and we stand, and then the camera person shoot this way quicker. So we go for quick lunch and come back quickly.
Yes.
Yes. Okay.
Let's do it together.